Hello, we're going to talk first about extraction of a maxillary bicuspid, grafting it with PRF, platelet-rich fibrin, letting that heal, and then coming back and placing an implant and a screw-retained abutment and crown. If you want the really good stuff, click on the blue link in the description below and subscribe to dentistrymasterclasses.com. That's where all my really good stuff is. Before and after, before and after. So, first part is going to be extraction and placement of platelet-rich fibrin. You'll remember platelet-rich fibrin is rich in growth factor. And so theoretically, things heal better and faster with PRF. A lot of times I mix PRF with freeze-dried bone, just because you've got more of something you can work with, kind of mixing it with sand, so you've got a form to pack into the socket. And sometimes I'll use freeze-dried bone alone, but I'm finding that it's a good combination to mix the PRF, platelet-rich fibrin, with the freeze-dried bone, just clinically speaking, and then put a resorbable collagen membrane over the top of it, so you end up with a flat surface. So we'll show how this works with platelet-rich fibrin alone grafting the socket. So you can refer to the link on how to give a painless mandibular or maxillary injection. It's so important that you give a painless and profound injection. So many dentists do not know how to anesthetize teeth. They really don't. I see patients in my practice all the time who say, they can't get me numb. Well, what do I know? I know they don't know about an intraligamental injection. They're trying to anesthetize the tooth for an extraction, endodontics, something significant, with just an infiltration or a mandibular block. Folks, that doesn't work. That doesn't work. And you have screwed up from the get-go if that patient feels anything. So, for heaven's sake, learn how to give a painless and profound local anesthetic. You've got to get the tooth numb. And if you can give the injection painlessly, that's kudos for you. People will come to you if you are a crummy dentist, but you can make it totally comfortable. So why not do the best of everything? Have you ever heard that phrase, I'm easy to please, I just like the best of everything? Well, think to the end and work backward. If you're doing a procedure, what ingredients does that procedure have to have so that it is perfect? Well, they all begin with painless and profound local anesthetic. If you can't get them numb, that patient is not going to like you. So with this technique, this is the intraligamental injection. That's imperative if you want to get a tooth completely numb, because there are accessory nerves that go to those teeth. And if you just give infiltration or a mandibular block, you're not going to get all the accessory nerves. This way, you get all the accessory nerves. That's a 30-gauge needle with the bevel turned toward the tooth, and the anesthetic is Stent plain, 4%. That's pH neutral. Don't use a local anesthetic with vasoconstrictor when you're giving the intraligamental, because if you do, you'll get an ulcer right there. You won't get an ulcer if you use Stent 4% plain. So the first thing I'm doing is trying to torque the tooth. Now, I don't want to lose the buccal plate. You could take this tooth out with the easy extract system, but it would be a little difficult because it's a two-rooted bicuspid. So I'm just trying to get a little movement, just torquing it, just turning it like you're unscrewing it. Then I'm moving it mesial distally. I'm not moving it way to the buccal because I don't want to lose that buccal plate. And then just unscrew it. There you go. It's a two-rooted tooth. When do we place implants immediately following extraction, and when do we graft the socket and let it heal? I like to place the implant immediately if we've got a good buccal and lingual or palatal plate. if it's a single rooted tooth, because you've got a perfect socket to put the implant into. If it's a 2, 3, or 4 rooted tooth, I graft the socket and let that heal for 6 months. Now, some of you, there's successful practitioners that let it heal for 3 months. I like to overkill, if anything. If I jump out of an airplane and they give me the option of 2 parachutes, I'm going to take it. So I know that bone's going to be completely healed in 6 months. I'm not positive it's going to be completely healed in 3 months. I'm going to curette the socket with a spoon. Check and be sure the buccal plate is still good. Irrigate it with chlorhexidine. And then I'm drawing platelet-rich fibrin. You can watch this link. Now, all these videos are in an organized library in dentistrymasterclasses.com. We've tried to keep it as cheap as we can. We don't make any money off of this. We're just defraying some of our cost of cameras, editor, a videographer, all the computers that have to go into making Dental Minute and dentistrymasterclasses.com. So it's $20 a month. And you get that organized library of all the Dental Minute videos, plus many comprehensive, complete cases that aren't in Dental Minute. So what we've tried to make dentistrymasterclasses.com is a highly advanced dental teaching center. You can learn everything from the basics of how to give profound and painless local anesthetic, how to bond teeth, to how to do a full mouth reconstruction, to how to do a full mouth extraction, place small laminar implants, securing removable dentures. So first we draw the blood and then spin it down. And we always spin it 2 cycles because we found that oftentimes 1 cycle is not enough. So it spins for about 16 minutes. And I draw the blood often before I extract the teeth, so it can be spinning and then flattening while we're extracting the tooth, which is what I did in this case. I actually drew the the blood, before I extracted the tooth. Then you place these little caterpillars, the yellow part, on the tray, the perforated tray, put the lid on top of them, and this squeezes the serum out of those little caterpillars and flattens them out, and that serum goes through the tray into a collecting pan below. I'm just cutting the pieces into smaller pieces. You can just plug the big pieces into the socket. It's hard. It's a little tricky plugging PRF into a socket because it's like Jell-O. That's why I'm finding it a little bit easier if you mix it with freeze-dried bone, because that's more like sand mixed with the PRF, and use the serum from the PRF to wet the freeze-dried bone. But in this case, we're just using PRF, and that works well. It's just a little trickier to get it in the socket. So be sure that you release the flap on the palatal, because you want to tuck the resorbable collagen membrane under the flap on the palatal surface and under the flap on the facial surface. I cut the corners off of the resorbable collagen membrane and tuck it under the facial and the palatal. Then I'm suturing this with 3/0 gut suture. You can either use 3/0 or 4/0. And don't pull it real tight, because if you do, the suture will pull through the flap. And when you're suturing, be sure you take a deep bite. Don't put the needle through the tissue right at the edge of the flap. Take a deep bite so it's solid. And normally in these cases, I'll do 3 suture. Sometimes I'll just use 2, but normally I'll do 1 on the distal, 1 on the mesial, and 1 through the middle, just to suture it tight. This is the final implant. Okay, so that's part 1. That's the Dental Minute. These techniques work, and they work every time.